Welcome to another episode of the NEI podcast. I'm Dr. Sabrina Siegel, live at the NEI Congress 2022. In this extended Q&A episode, we take some time to sit down with one of our incredible speakers and allow the audience a chance to have their unanswered questions addressed from selected presentations. In this special episode, we're on site at the beautiful Broadmoor Resort in Colorado Springs. In this episode of the NEI podcast, I have here with me today Dr. Adelaide Robb, and she just finished her presentation on the assessment and treatment of pediatric impulsive aggression, a transdiagnostic issue. And we have a chance to get some of your unanswered questions addressed in this episode. I'm so excited to have Dr. Robb with us here today. Welcome.
Thank you, Sabrina, for having me. It's fun to do a podcast because I think it lets us focus in again on a topic, but not be stuck looking at slides.
Yes, absolutely. So the first question I have for you is, how likely is it that children with post-traumatic stress disorder, or PTSD, have severe aggression?
It's actually fairly common.
Okay.
And the reason is they're already hyper-aroused. That's one of the symptoms of PTSD. And so they can be very jumpy, easily scared, internally preoccupied. And when they're startled, we always think of PTSD as doing the flight response, but sometimes they do the fight response. And they may get in fights at school and things like that just because of the PTSD that's not adequately treated.
Right. That makes sense. The next question is, how is DMDD different from intermittent explosive disorder?
And this is a great question because I brought it up. DMDD is really a disorder that has its origins in childhood. And if you go back over the DSM criteria, you remember you have to have a chronic level of anger and irritability with intermittent explosive behaviors that is very impairing and out of proportion and starts at a young age.
Okay.
When we think about intermittent explosive disorder, we're really talking about the 40-year-old man who gets in a fight with his boss and yells at him.
Okay. So it's more of a distinction between adulthood versus earlier in life.
Yes.
Okay. The next question I have is, it's someone who says, I have parents frequently asking me about the internet's and Facebook's most beloved treatment, the infamous Matthews protocol. Have you used this and had any success? This person asks.
And I'm going to be very honest and say I have not used the Matthews protocol.
Okay.
So I can't answer that question.
Okay. All right. Then we'll move on to the next one. Why was methylphenidate chosen over an amphetamine, such as Adderall, extended release, for the study to treat ADHD and major depressive disorder?
People used methylphenidate because it tends to have a lower rate of emotional ability as a side effect.
Okay. Good answer. Short and sweet. The next question I have for you is, what are realistic expectations behaviorally to discuss with families about treatment success? And this person says, I often encounter families who have unrealistic expectations for treatment, so I find it helpful to set those expectations in advance. What would you say about that?
I think that's an awesome way to set up treatment with the family.
Yeah.
And I think what I like to do is have short-term goals and longer-term goals. And so short-term goals might be, if we've got a child who's punching people on the school bus, reducing the level of aggression so there are no longer fights on the bus is a short-term goal. And maybe a longer-term goal with therapy and medication and maturation might be a polite and respectful, obedient child.
Right. I like that. Okay, the next question I have for you is, how did the kids in the Tobin study do after a year or after they stopped the medications?
I think that we would have to look back and see if there's been a follow-up study that's come out from Dr. Tobin and his group at NIH.
Okay.
Since this one was only published a couple of years ago, I know they're continuing to collect data, and I think we will get more updates as those children mature.
Oh, that's great. That's wonderful. The next question I have for you is, would you consider Lexapro instead of Celexa for ongoing irritability despite well-treated ADHD on a stimulant?
I actually would, primarily not based on the study, but on the fact that Lexapro is actually FDA approved to treat adolescent depression.
Right.
And so we know the dosing and we know what kind of symptom improvement we could see.
Okay. Next question. Any studies, this person says, any studies in using methylphenidate and atomoxetine together for aggression in kids with ADHD?
I've seen a study of atomoxetine and methylphenidate that was done by Dr. Willing's colleagues at MGH, but that was looking at improvement of ADHD and not specifically at irritability and aggression.
Okay. The next question says, what percentage of patients with DMDD have a history of trauma? And for our audience, can you explain what DMDD is, just in case for some of our listeners?
Right. So DMDD is the disruptive mood dysregulation disorder. So it is kids who have a chronic level of anger and irritability that has an onset at a young age. So we're not talking about a 3-year-old,
right?
But we're talking about before the age of 18.
Okay.
And they intermittently become very volatile and aggressive. They explode frequently on top of a sort of a simmering pot of anger.
Okay. So I know we sort of took a detour to explain DMDD, but the question is asking, would you say that most of these patients have a history of trauma?
I would say that some of the patients have a history of trauma, but when they were going about making the diagnostic criteria, they did not want this to be a variant of PTSD. So it's one of the exclusionary criteria.
Okay. So they have been exposed to trauma, but they should not also be diagnosed with PTSD.
Correct.
Okay. Next question is, if a kid has depression and irritability, how do you rule out bipolar disorder, since hypomania and mania often occurs later in the teenage years?
That's an awesome question. And I say that because we probably every 6 months will see a child come back to the hospital who presented with depression, was successfully treated with an antidepressant, and comes back with bipolar disorder.
Wow.
What I would say is irritability and depression is not an indicator that you're going to turn into bipolar.
Right.
I'd be more concerned if somebody came in with psychosis and depression.
Okay.
And a family history of bipolar disorder puts me at massive high alert.
Yes. There you go. Now that takes me to our final question, which is, have there been any trials with cariprazine in autism-related irritability and aggression?
There have not, but they are underway. And if you go to clinicaltrials.gov, you can find out what sites are doing those trials.
Excellent. Well, thank you so much, Dr. Robb,
you.
for being on our show and for giving the audience a chance to get those unanswered questions addressed. What an excellent presentation. Thank you so much.
Thank you, Sabrina, for having me.
Thank you so much for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today.